Hello, my name is Simon Niclou. I have been working in research in Luxembourg for 18 years at the Luxembourg Institute of Health before taking up the position of Vice Rector for Research at the University of Luxembourg.
My name is Guy Berschem. I'm a medical oncologist and I'm in the research environment in Luxembourg for more than 20 years. When we established our first lab in the Luxembourg Institute of Health, which was called CRP Santé at that point.
My research focused on cancer research and specifically on cancers that affect the brain. There are many types of different brain tumors, and we focused on glioblastoma, which is the deadliest brain cancer.
The focus of my research has started with cell death mechanisms for oncology. That's very important to understand why cells do not die anymore when they should and when they are ill. And it has evolved through the field of immunotherapy now, looking at the mechanisms of how immunotherapy works and how cancer cells are attacked or not attacked by the immune system, and thus the evasion mechanisms of cancer immunotherapy.
Guy and I were actually at the beginning, at the basis of establishing the Department of Cancer Research at the LIH. His lab was focusing more on blood cancer and my lab focusing on brain cancer. But of course we shared a lot of, let's say, the initial enthusiasm and dynamism in setting up something new.
With the help of my first FNR grant in 2003, I think, we had the chance to establish this, at that time, first oncology lab at the CRP Santé. But very, very quickly after me came Simon Niclou, and together we could go towards the establishment of a cancer department, cancer research department at the CRP Santé and later the LIH. So she was very, very helpful, and she's a wonderful scientist, and together we could really make many things happen.
Later, when we set up the clinical cohort on patient-based models, Guy was very instrumental in providing us clinical data of the patients.
What is important for a cancer researcher is to have the relationship with the clinic. And what we were able to do in CHL was to give the neuro-oncology lab of Simon Niclou this link and give her the data from the patients that I'm in my clinic and seeing, and she in the lab has the samples of. And I think that is still ongoing and is a very important part of the collaboration between clinicians and researchers.
My team challenged the prevailing cancer stem cell hypothesis in glioblastoma by demonstrating that most cancer cells are highly adaptable, able to take on stem cell traits to survive and thrive in the brain. This was a challenging task as the hypothesis was very entrenched in the literature. We also made a major contribution by establishing a large internationally recognized cohort of preclinical patient-based models, such as organoids and PDOX mice, and this has allowed to engage in many international collaborations.
I think the field of immunotherapy has been a highlight of my career as an oncologist, and certainly also as a researcher, because we have tried to analyze these resistance mechanisms and even found some very interesting findings in that field. To better understand why some tumors are what we call cold, so not amenable to immune therapy.
The major challenges are improving treatment and the survival of patients. Glioblastoma is a rare cancer. It affects about 4 people in 100,000 people, yet almost everyone knows someone who has died of glioblastoma. Affected patients normally die around 1 to 2 years after diagnosis. So it's a devastating disease, and any improvement in treatment and life prolongation will be very meaningful.
I think the future in oncology, at least, and in cancer research will be more and more the active immunotherapy. When I say active immunotherapy, I mean the CAR T-cell treatments, so the modified T-cells from the patient that are re-injected after the cells have been made more aggressive towards the cancer, and other similar types of immunotherapy that will, I'm sure, develop and be able to even cure some cancer.